Good morning, everyone. Thank you for coming to spend your morning with us, and welcome to the MGFA scientific session. I am Samantha Masterson, and I have the honor of serving as the president and CEO for MGFA. I have to say, last year, due to COVID, last year was my first time being part of the scientific session, and it was such an amazing experience. And as I understand it, it has been growing significantly every year, and I can see this year we likely will also have standing room only again, which will be just a phenomenal thing, and I think it speaks volumes of where we are in the MG space in general. The scientific session program was born to bring neurologists and other physicians together to discuss their basic and clinical research. And it's really an important platform, and MGFA is really proud to certainly serve that role as a convener. We really consider that to be a very important role that we serve for the MG community. This is the second largest program that we host in the fiscal year, aside from our annual national patient conference. So this is the largest scientific symposium, certainly, that we host. And just to demonstrate the growth year over year, we had double the amount of abstracts this year. We had 76 abstracts submitted this year. So that is just a phenomenal thing in a space where there is tremendous, tremendous movement right now. So again, thank you for joining us this morning. I only have a few moments with you. We're on a really tight schedule and there's a clock, and so I want to pay attention to the clock. And I do want to thank those volunteers who have played a pivotal role in planning the session on behalf of the organization. It really does take a village. We have a lead staff member, and so I do want to thank Dova Levin. She is the lead team member who plans this conference and does it so flawlessly. And I want to thank our committee too. And I'm going to look down. I'm very familiar with our committee members, but I want to make sure for those of you who are new in the room and are not familiar with our steering committee members, I want to make sure that I get their affiliations correct. So I do want to thank Dr. Ali Habib, who serves as the chair of the scientific session steering committee. And Dr. Habib is with the neuromuscular medicine with UC Irvine in Southern California. And then we have Dr. Diana Castro, who's with the Neurology and Neuromuscular Care Center in Denton, Texas. And then we have Dr. Neelam Goyal, who's with the Neuromuscular Program with Stanford. So I do want to give those volunteers a round of applause for their help over several months of planning this scientific session. Okay, so we are streaming. So we will also have a virtual Q&A at some point throughout the program. So I do want to let you know that we're not the folks in the room are not the only ones participating for this session, so that's really exciting. And now I want to introduce Dr. Habib to come to the podium to introduce our keynote speaker. Thank you.
Good morning, everyone. Thank you for being here on behalf of the Scientific Session Committee. It's a pleasure to be here as chair. Having a chair means you get asked to sit down a lot. So I'm just going to take 2 minutes of standing before I do sit down. It is indeed our pleasure to introduce our keynote speaker this morning, Professor Anna Rostat-Panga, coming to us from Sweden. I very recently had the privilege of meeting her. She's had an illustrious career in the field of myasthenia from the very early days, starting working with Dr. Don Sanders and also having worked with Dr. Eric Stolberg, and really is bridging the lab and the clinical world really wonderfully, bringing forth really key information leading to biomarker discovery in the field of myasthenia. You know, the reason that this room is so full is because we've had tremendous gains in terms of therapeutic developments, and now we have a very interesting conundrum. We have really effective therapies, and we are beginning to wonder how exactly to use them and which patients are the most suitable for use of them. And I think work from her and others in the field is going to be really critical in driving our decision-making in an informed way. So without further ado, Professor Panga. I forgot to mention, I did ask her this morning as a clarification, how many she's had over 67 publications and counting.
Thank you for this introduction, Dr. Habib, and also thank you for the invitation of having this speech today. So actually it was 24 years ago I first received a fellowship from the Myasthenia Gravis of America and Henry R. Wheat's fellowship, and that started my MG research actually, and I am still here. So, is the presentation? Yeah. So these are my disclosures. So all of you know that MG is a very heterogeneous disease, and that is one of the big problems that we are facing. So it's one disease, but it's a lot of different subtypes. And some of these subtypes are based on the antibody status. So it's the serological groups of MG. And those are the AChR positive, myasthenia, acetylcholine receptor antibody positive, the muscle-specific tyrosine kinase, MuSK positive patients, the patients who have LRP4 antibodies, and also what we call seronegative. So if patients lack antibodies against all of these receptors. We also have another group of a subgroup which is based on age at onset, and those are the early onset, the juvenile onset for children below 18 years of age, and the early onset 19 to 50 years of age. And this is something we have divided, usually based on the thymus hyperplasia in patients who are below the age of 50. And late onset are the patients that we divide older than 50 years of age, and that's because they usually don't have a thymus hyperplasia. And then a new group have arisen, the very late onset group, which is over 65, because patients nowadays, thanks to new treatments and very well care, is that survive very long. So we also have this other group. In addition, we have the clinical phenotype, where we distinguish between the ocular patients who only have ptosis and diplopia, whereas the ones who have generalized disease have weakness and fatigue in muscles outside of the ocular area, in facial and limb muscles. And then we have the last group that we consider a subgroup, which is a thymoma-associated myasthenia gravis. The problem is that we don't have molecular subgroups. We have all defined these groups ourselves based on different features, especially during all these years we've done the research, but we are lacking molecular subgroups, especially for follow-up of patients and determining which ones should have the right treatment. And further, the clinical course of MG is very unpredictable. We may have patients remaining ocular for the entire course of the disease, whereas some generalize and become very, very sick of the disease and get a myasthenic crisis. And at the moment, we don't have any tools to determine which of these patients actually will have to have a more aggressive type of treatment initially in order not to have a myasthenic crisis. So biomarkers are indeed a very hot topic in MG. And I will just quote a publication from 2012 by Kaminsky and colleagues, saying that although the path to validation of a biomarker is long and arduous, the payoff is enormous for patients, the field of research, and is now a reasonable undertaking with the tools that are at hand. So if you see this PubMed search, we see that there are not a lot of publications before 2012, and then something happens and it peaked. So a lot of studies are now focusing on biomarkers, and we are very happy for that within the myasthenia community. And we need to know then what characterizes the ideal biomarker. How should we define the perfect biomarker for myasthenia? So it has to have biological relevance. It has to have importance for what happens in the pathophysiological process of myasthenia, which is the immunological response and also the attack of the neuromuscular junction. Has to be sensitive for myasthenia and also specific, not to be able to be too broad. Has to be quantifiable. If we want to have a follow-up of this biomarker, we need to be able to quantify it and follow it over time. It has to be non-invasive. So, for example, having a thymus sample is very invasive compared to blood sample, which is less invasive. Accessible. So also, I think that a biomarker will never be used if it's not accessible all through the world and also down to many clinics around the world. Has to be stable and reproducible. So if I take the test, someone else takes the test and analysis, it has to show similar findings so that it's not an arbitrary finding. It has to be clinically relevant, so it has to matter for the patients and the outcome, and hopefully it can predict the outcome for individual patients. And finally, it has to be cost-effective. So everything we do is also something has to be paid, so we have to think about our resources in society. So with that said, what do we have to choose from in MG? So we have, of course, what everyone knows very well, the clinical outcome, disease-specific outcomes, and those can be objective, clinical physician-assessed, or they can be subjective, patient-assessed, or we now have also, of course, the new era of telemedicine with new outcomes. It can be based on electrophysiology, where we measure actually what happens at the neuromuscular junction with neuromuscular transmission. It can be from the thymus, especially then in the thymoma-associated myasthenia, where we anyway want to remove the thymus. It can be blood cells from plasma, can be antibodies, metabolomics, proteomics, or circulating microRNA in the serum. So you see we have a lot of different choices. So the question is, which way should we go? And I will give an overview of where we are today. So starting with clinical outcomes, most of you are familiar with the clinical outcome scores that we use for MG today. And in this table, the most common ones are summarized. And we have the quantitative Myasthenia Gravis score, QMG. We have the Myasthenia Gravis activity of daily living, MG-ADL, which is patient-reported. And we have the Myasthenia Gravis composite score, MGC, which is also physician-based. And the QMG and MGC are objective because they are physician-assessed commonly, but also dependent on the evaluator. And the downsides is that we have fluctuations within days and also between days, and it's difficult to adjust for that. And MG-ADL is more subjective. And also different muscles obtain different points. And is it correct that we weigh, for example, limb muscles differently than bulbar muscles? So that's a philosophical question, but it's a problem sometimes when we measure the degree of disease. And then the new era of telemedicine. This is a publication from Guidon et al. Quite recently that launched the MG Core exam, MGCE. So this is, of course, a very nice tool to be able to assess patients online, but there's also a difficulty to assess certain muscles because of the online scenario. Then we have, of course, our favorite examinations. At least my favorite examinations are repetitive nerve stimulation and single fiber EMG, where we can measure to a very, very detailed extent the degree of neuromuscular transmission failure. And it has a very high sensitivity, especially single fiber EMG, where we can look at these jitter and blockings, which tells us exactly how disturbed in microseconds the neuromuscular failure is. However, this is not available in all clinics around the world because of the expertise being demanded to do these examinations. And also, it has a rather low specificity, especially single fiber EMG, around 70%, And what is happening nowadays is more and more people get botulinum toxin injected in the facial muscles, which also, of course, disturbs the specificity of these examinations. So for thymoma-associated myasthenia, we would like to have a thymus signature. And there was a very interesting publication out last year in Nature Communication by a Japanese group looking at actually what could be the reason of thymoma patients developing myasthenia. And it shows that some of these are the expressions of different molecules in the thymus tissue in MG patients and thymoma patients that don't develop myasthenia. And what they found was that the thymic epithelial cells from patients who develop myasthenia express neuromuscular markers. So that could be a reason why some of these patients then with thymoma develop myasthenia. And also they signal through these chemokines, which I will come back in the end. Chemokines seem to be very, very exciting in the field of myasthenia. So that is how T and B cells signal also within the thymus, and they managed to find this particular signature very, very interesting for the thymoma patients who develop myasthenia. So how about antibody levels? Many people think, well, we just measure antibody levels and they will tell us what will happen to the patients. Unfortunately, that is not always the case. So this was a large meta-analysis done of all the huge amount of studies where antibodies are mentioned. And it included the AChR antibodies, MuSK antibodies, titin antibodies, LRP4 antibodies, and ryanodine receptor antibodies. Also, the voltage-gated calcium channel antibodies in Lambert-Eaton myasthenic syndrome. And as a matter of fact, when you cook it down, there were only 42 studies that actually fulfilled the criteria of being longitudinal, that is to follow patients over time, or to correlate the antibody levels with the clinical scores. So as you see from the table also, the X is the cross-sectional studies, and the one marked within this sign show that there was longitudinal follow-up. So in light of this limited amount of data, routine clinical use of antibody levels in the context of a biomarker is not recommended. Still useful, of course, especially for pregnant women where we want to follow if there is a chance for the baby to have neonatal myasthenia and so on, but not in the context of a biomarker. Something exciting that also recently came up, I was in the committee of a PhD student, Miriam Fichtner, defending her thesis in Maastricht, and she has worked closely with Kevin O'Connor at Yale, and actually looked into MuSK myasthenia. So there it seems that we get, actually this is a graph showing patients over time receiving B-cell depleting therapy with rituximab. And they measure these type of clonal variants of antibody-producing B cells against MuSK. And they actually reappeared after some while, these clones, actually before patients developing clinical symptoms. And I think that's really exciting if we can have a marker in MuSK myasthenia, then can predict actually the reoccurrence of symptoms once in remission after B-cell depleting therapy. And this actually happened, the prediction, by several months. And I think this is something, if it's planned exactly how and how often it needs to be assayed, it's very exciting. Now we come to blood cell markers. So we have two choices. We can look at the actual blood cells, the B and T cells mostly, or we can look at serum. So in this case, it's been attempt to profile the T and B cells in MG. And since they're also present in the thymus, it's believed to be a signature also how the thymus hyperplasia is occurring in the periphery in the blood. And with the techniques coming now with the mass spec cytometry and single cell profiling, this is actually now a reality. So this was one of the studies by Ingelfinger and Bettina Schreiner who looked at the single cell profiling of MG and that identified a pathogenic T cell signature in the TNF, so tumor necrosis factor, producing TH CD103 cell subset as a promising cellular marker of disease severity in myasthenia. And it was then different in patients who had undergone thymectomy and those that had not, and it was much lower in patients received azathioprine and also those that received azathioprine and thymectomy. So this could potentially, if validated, become a blood cell signature to see what patients would respond to therapy. So number 2, this is something, as I said, the mass cytometry, which is now available in many, many countries, and that allows for global studies. So this was a more recent studies by another group looking into, again, blood cells. And they found that the number of these HLA, DQ, CD38 plus naive B cells was higher than in generalized myasthenia patients than in healthy controls. And it correlated with the quantitative myasthenia gravis score. And also the number of CD56 positive, CD16 plus NK cells. You have to be careful when saying all these very, very long words. And the CD56, CD plus, CD16 plus, CD8 plus NK cells were decreased in MG patients and also positively correlated with the QMG score. And also a certain amount of monocyte V-domain Ig suppressor of T-cell activation, VISTA positive monocytes were increased in myasthenia. So hopefully some of these signatures can be validated potentially as blood cell biomarkers in myasthenia. So what about the complement system? We have now the new complement inhibitors as treatments in myasthenia, so it would be very good to actually focus on having some of the markers showing what happens to the complement system. And just to, again, be brief, I think most are familiar with the complement system, but you may not have all of these factors in your head. You don't think about them every day. So what happens in the complement system is that we have the classical pathway where we have an activation of the C1q, and then we have a further activation of the C3, which is then cleaved into C3b and C3a, and then further activating the C5 pathway and assembling then these molecules C5 to C5-9, C5b to C5-9, and that will generate the membrane attack complex, the MAC, which we believe is very, very important for the damage at the neuromuscular junction and what the complement inhibitors actually target. So how about that? Could we use complement factors as biomarkers? So it's very important to know that when you measure complement factors, you have to do it to get the right levels in plasma. Because that inactivates the factors and you have a more relevant level of them. If you measure them in serum, they keep on activating, so actually outside of the body. So it's important to measure them in plasma for this biomarker purpose. And one study from 2022 by the Mantegazza group found that it was increased levels of C3b and C5a. It was a quite low number of patients, so we had 18 AChR positive patients and 14 healthy controls and 5 MuSK patients. So we don't expect complement activation in MuSK patients, but of course only 5 patients is very low to say if we have that or not. So at least these 2 markers, the C3b and C5a, were found increased. But I think also in these studies, we need to have a high number of healthy controls because there is the spread within what we call healthy individuals as well of these markers. So these are unpublished data from our lab, also in plasma, where we have looked at 140 healthy controls, 1 patients AChR positive and 2 seronegative, and we see a major increase in C5b to 9, so basically what accounts for the membrane attack complex, which is not surprising, but still it's very nice to show it. And also C3a. So in conclusion, we have C3b, C3a, C5a, and C5b to 9, which are increased in 2 different studies. And potentially those can be important as the complement factors to measure in these type of trials and also in clinical follow-up. Then we have something called serum free light chain, FLC. And this is something which is elevated in different hematological conditions, including myeloma. So it's not specific for MG. But an Israeli study found that it's actually elevated in myasthenia compared to healthy controls in serum and also in ocular patients, which is of course important. We need to have something which is also elevated in ocular patients, not only generalized patients, because even if we think that ocular myasthenia is a lighter version of the disease, these patients are very impacted by the ocular disturbances. And also in seronegative myasthenia, it's elevated. And also the group of Gambino et al. Were able to reproduce these findings. Then actually a very recent study from Dr. Kaminsky's group came out now in October showing serum metabolomics. So they have been looking into the randomized controlled trial of thymectomy, the MGTX trial, where they have a biorepository of samples and serum samples. And they actually found that they wanted to look at the patients who responded and did not respond, especially to cortisone in this cohort. And they wanted to correlate the early baseline data with the response at 6 months. And they found that histidine and free fatty acid, gamma cholesterol, and guanosine had a very high predictive value of being a responder to cortisone, as you see in this graph. And they suggest that xenobiotic metabolism is suggested to play a major role in a corticosteroid treatment resistance, so for those patients who do not respond to cortisone, which adds as another player in the potential factors of measuring when patients do not respond to treatment, to know what treatments to target. Then what we've been looking a lot into are the serum microRNA. So these are small non-coding RNAs binding particularly to their mRNAs on the proteins. So what they do is they reduce the levels of those proteins by reduced translation and production. So just summarizing what we have found in these different microRNAs. So we have found specifically one microRNA, MIR155P, which actually regulates T-cell development and differentiation, has been very highly elevated in especially early onset AChR-positive myasthenia. It's also been elevated in late onset myasthenia, together with another T-cell important microRNA, MIR215P. And then another player here, MIR30E5P, has been shown to be higher in ocular AChR-positive patients who later generalize than those ocular patients who remain ocular. And in MuSK myasthenia, it's a totally different profile of serum microRNAs, which is not totally surprising due to the very big, actually, differences in AChR-positive and MuSK myasthenia, both pathologically and clinically. And excitingly, MIR155P is also reduced upon thymectomy, when we looked at this in the MGTX trial, and on rituximab. So it seems to correlate with treatment response in some of these studies, and also in particular before and after treatment with thymectomy and rituximab. And the follow-up study showed that MIR155P is sensitive, especially for early onset myasthenia, about 90%, but it has a rather low specificity. So with single fiber EMG, the same. So the specificity is lower. And we looked also into other patients with other neuromuscular diseases, such as multiple sclerosis, and they also had higher level of MIR155P. So sometimes I think we have to think about that there may be a common denominator in neuroimmunological disorders as well. And regarding miR30E5P, it's more specific. So it has a specificity of 86%. This is based on around 200 healthy controls, and also this control group of other neuromuscular diseases. It has a lower sensitivity of 56% compared to miR150. And also, we noticed that patients with lower levels of miR30E5P, they had a lower risk of actually going into a relapse of the disease than patients having a high level. They were more prone to have a relapse or worsening of the MG with an odds ratio of approximately 3. And this was the previous study where we looked into the patients who had ocular myasthenia, later generalizing, and they also had higher levels of miR30E5P. So it would be exciting to know whether we could assess this very early on when a patient comes in a diagnostic setting and know exactly what would happen along the road if that patient should have more aggressive treatment and be treated earlier on. One important aspect is that many of these studies have looked at long-term outcome of these different microRNAs. And we have now very, very recently looked at, these are unpublished data as well, so short-term changes in microRNAs, 30E5P and miR155P and 21. So these are patients being followed at our hospital in Uppsala, 39 MG patients, and no differences in treatments were done during this follow-up time of 1 month. So they came in for weekly assessments with the serum samples and the MG-ADL. And what we see is that the levels of miR30E5P and miR155P are totally constant, so they don't change between the weeks. Whereas miR21.5P changes, and there's another study in bariatric surgery looking at miR21.5P, also seeing that it changes very rapidly. So with this in mind, the miR30E and 150 seems more reliable with not having these short-term fluctuations. Interestingly, the MG-ADL significantly changed from week 1 to week 2, probably because of the placebo effect of being in a trial where you're being taken care of. Even if we didn't do anything to the patients, we saw a significant decrease in the MG-ADL. There's been another Italian study by Paola Cavalcante and colleagues in Milan. And they have also looked into microRNAs that could predict the pharmacological response. And they found that they also work with the Israeli group of Talma Brenner, and they found that these microRNAs, 323B, 3P, 409, 3P, 485, 3P, and 181D, and 340 could predict responsiveness in MG patients. So that is also something that I hope they continue validating for the immunosuppressive response. So now we'll also go into something very exciting, proteomics. So proteomics has been out there for quite some time, but not really focusing on myasthenia that well. So this was also a submitted manuscript, but it's unpublished data. So it's a follow-up study of the study we did in 2016. We used the Olink platform, which is an Uppsala-based company. Now it's a huge one, but it's actually based in Uppsala from the beginning in Sweden. And it uses very specific antibody pairs that connect to the proteins and that allows us to measure proteins on a nanoscale level. And we had a team up with the Latvian team in Riga, and we included almost 100 AChR positive patients, 98 patients, and 77 age and gender match controls. And with the duration of approximately 6 years of myasthenia, MG-ADL ranging from 0 to 16, major group had immunosuppression, and there was half and half almost late onset and early onset myasthenia. So I'm sorry about the very, very small font here. It's just to show basically some of these graphs totally go things where they don't overlap at all, so they are totally separated. And that is always exciting. You know, if we can have levels of proteins that totally distinguish myasthenia from healthy controls, then it's easier to use it as a follow-up test, to have it yes or no kind of a way. So we did find that in many of these proteins, and since we tested for so many proteins, 92 proteins, we needed to use a very, very low significance, or high, how to say it, but a p-value of less than 0.0006. So still with that, we found an inflammatory profile of proteins that totally separated healthy controls from AChR-positive myasthenia. So these proteins here on the higher end to the left, they are down-regulated myasthenia, and these are up-regulated. And we used biostatisticians for this study because we have to always think about, you know, the significance in statistic regarding, and also contra the clinical relevance of the data. So we use something called the Forest and Baruta algorithms, and that is something that you test on repeatedly until you get what biomarkers fall out and which ones are the ones confirmed. And we found some of these biomarkers with an extremely high odds ratio, and that clearly separates myasthenia. And one of them is the chemokine, actually. We talked about the thymus signature before in thymoma myasthenia, and one of them is CCL28, the very highest one. So interestingly enough, there seems to be a link also between the microRNA 30E5P and 155P. They negatively correlate with several of the proteins that are downregulated here. So when the microRNAs are high, the proteins are low. So what we believe happens here in AChR-positive MG is that we have an elevation of these immunomicroRNAs, especially miR150 and miR30E5P. They bind to their target proteins, and they reduce. So this is a protein, this green blob here. And it reduces the levels of these particular proteins very specifically. So based on this study, we have now constructed a map on the different pathways of proteins that we believe are targeted in myasthenia, and that also are important. And we see that some of these factors, I mentioned previously in the blood cell signature, the tumor necrosis factor family. So indeed, we have a lot of these members of the TNF superfamily, which also correlates indirectly with all of the microRNAs that we measured, and that also correlates with the clinical severity. So these are really exciting data, I think. So lastly, what about digital biomarkers? So there's a digital era, as we said in telemedicine. Can't we just have a tool and that would measure a lot of different factors on MG patients, and that would be fine? So we are now running RCT in Sweden called Digital Phenotyping and Lifestyle Intervention in patients with MG. And it's actually recruiting. It has recruited a lot of patients already. And so we will determine whether the digital interventions on physical activity and sleep will improve MG-ADL. That has never been done before, believe it or not. And so we will use exploratory outcomes there, something called the Aura Ring. And that is a smart ring, not a smartphone or smartwatch, but it's a smart ring that you put on your finger, and it has sensors measuring the heart rate, sleep pattern, and also how much time you're in moderate activity, and temperature. So this is also very exciting to see, do we have any digital biomarkers that we can use? Because they, of course, upload data via Bluetooth to the server, and you can monitor also over distance. So I have a dream scenario for biomarkers in myasthenia. That is, we have the patients, we take a blood sample, and based on the blood sample, we can generate a profile on microRNAs and proteins, and potentially also complement factors that we know are important for the disease. Then we will have non-invasive and quantifiable biomarkers. They will be stable and reproducible because we know that these are stable actors. And we can use also, and hopefully they are sensitive and specific. And they will have biological relevance for what happens in the immune response, triggering a clinical response. And they will also be then clinically relevant. And in order for everyone to have access to this, because everyone does not have access to quantitative real-time qPCR or OLIG platform, which, by the way, are extremely expensive, we have to make some kind of plot test, this kind of point test, where you can actually put a little sample of serum, and it will tell you in what direction it's pointing towards the patient. So that is my dream, that we have a quick test for these biomarkers based on what we know and the quantification of these data. And that will also make it cost effective. So then I think that we will solve the puzzle of MG biomarkers in myasthenia. And I do think we can see that in a couple of years. That will also allow us to have molecular subgroups of the disease, which we don't have today. We have created these subgroups ourselves that we have today. And that will help us towards being monitoring of the prognosis and treatment of the disease for each individual patient. So we heard that, you know, it takes a village and it takes a team to do all of these. So I would like to thank our myasthenia team in Uppsala and also the collaborators around the world, especially in this case, Victoria Kenina at the Paul Stradins University Hospital in Riga, our great biostatisticians and the nurses at the neurology department at Uppsala University Hospital, and MG patients all over the world and in Sweden, also our organization in Sweden, NeuroSweden, and also the funders, because these are very, very expensive projects to run. So with that, I would like to say thank you for the attention, and from beautiful Uppsala. No questions? Okay, thank you.
All right, so then now we can get started with that lovely talk on our main session. So our first session, if I can ask our presenters for this session to come up on stage, that'll facilitate time between talks. So Dr. Lee, Dr. Gennardi, Dr. Narayanaswamy, Adrian Keelhorn, Dr. Roy. Careful. So we're doing great on time here. This next session will have several talks. It's a mix between two different main hot topics, continuing on the biomarker discussion with a couple of brief presentations there, and then also talking about some challenges in the clinical care of myasthenia. So that so we'll keep the questions for all the presenters at the end of this session. If I can have, let's see, Dr. Lee.
Good morning, everyone. My name is Kevin Lee. So my topic for today is imbalanced immune cell profile in the thymus of MG. So to get started, here's a brief background of this study. So at the neuromuscular junction, the acetylcholine is released from the presynaptic membrane and binds to the acetylcholine receptors on the muscle, initiating the muscle contraction. So in MG, the presence of AChR antibodies leading to the degradation of acetylcholine receptors, resulting in muscle weakness and fatigue. So the formation of acetylcholine receptor antibodies involves collaboration between T cells and B cells, which leading to the generation of high affinity of all the antibodies. So in the clinical setting, approximately 80% of the generalized AChR post-MG patients exhibit pathologic changes in thymus. Among this group, 50 to 6% present thymic hyperplasia. So here's a growth of view of the thymic hyperplasia. So also, studies have shown that thymectomy significantly improves the symptoms of MG and reduces the daily prednisone dose. So this research not only validates the therapeutic benefit of thymus removal in MG patients, but also implies a role of thymus in the MG pathogenesis. So when quantifying germinal center per low power field, a correlation emerges between the germinal center numbers and AChR antibody levels. So the accumulating evidence suggests the thymus does play a role in the pathogenesis of MG. However, the immune cell profile in the MG thymus and in peripheral immune system are not well understood. So to better understand the immune profile of MG thymus, so we used thymus samples and peripheral blood from the same MG patients who underwent thymectomy. We applied the single-cell RNA sequencing technique to explore the immune cells and included age and gender matched health control from the public dataset. So through our analysis, we identified 23 distinct cell clusters within the thymus. So this slide shows the UMAP. So the UMAP clustering and the annotation in single-cell RNA sequencing visually represents each cell as a dot. Cells with great similarity are positioned closer together. And when comparing the clusters, single-cell RNA sequencing can distinguish the health control and MG thymus, and indicating an imbalance of the immune cells in the thymus. So in the PBMC single-cell RNA sequencing dataset, we identified 24 distinct cell clusters. This visual representation shows the cell clustering and the annotation. And this slide shows the overall differences in immune cell composition within a PBMC between the health control and MG patients. So it also indicating an imbalance of immune cells in the PBMC cells. When conducting a subgroup analysis of immune cell subsets, so we discovered distinct changes between health control and MG patients in both of the thymus and the PBMC samples. And when we further conduct the pathway and enrichment analysis, and we observed that the B cell population exhibits strong BCR signaling and activation, as well as increased transcription and splicing activity. So this suggests that this B cell population were more activated in MG patients compared to the health control. So applying the similar strategy to analyze other subsets of immune cells, so we identified highly activated NK cell, CD4 T cell, and double positive T cell in MG patients. So when we're combining the PBMC and thymus tissue data, and we explore the correlation of immune cell immune cells between the thymus and the peripheral. And we observed that the NK cell and the B cell increase in the thymus, but decrease in the peripheral, while double positive T cell decrease in the thymus, but increase in the peripheral. And the CD4 T cell exhibit an increase in both of the thymus and the peripheral. So to summarize, so our data suggests that the activated B cell and NK cell enriched from the peripheral to the thymus, and while the double positive T cell and CD4 T cells enriched from the thymus tissue to the peripheral. So for the next step, our future spatial single-cell eye sequencing data will just further validate the interaction among these immune cell types in the thymus. So last but not least, I'd like to thank many collaborators listed here for this project. And I'm happy to take any questions at the end of this section. Thank you. So next, please welcome Dr. Candela.
All right, good morning, everyone. So today the title of my talk will be Developing a Biomarker for Tracking Antigen-Specific T Cells in Myasthenia Gravis. Oops. There we go. All right. So I won't spend too much time on this slide because there's already been a couple of great talks today talking about autoimmune attack on the neuromuscular junction. But the intention of this study was basically, as we're starting to grow the field of immunotherapies that are available for MG patients and starting to look at therapies that can modify T cells, which is upstream of B cell and antibody production, we need to define biomarkers for T cells that can be used as a measure of response to treatment. So the intention of the study, we performed a study in 9 myasthenia gravis subjects that were AChR antibody positive, generalized MG patients, and then used a flow-based cytometry approach to track antigen-specific T cells in peripheral blood. And just a little bit of background, literature has shown that within the AChR antibody positive MG patient population, T cells do drive MG pathology. And also T cells have been used as biomarkers in other diseases, autoimmune diseases, including type 1 diabetes, in peanut allergy and celiac disease to track response to treatment. Just an example of that, we performed a study in celiac disease patients. In this patient population, challenge to gluten and change in villus height grip depth is a marker of disease severity. So when we treated these subjects with an immune-modifying therapy that reprograms T cells, essentially the subjects no longer had a response to gluten challenge by no change in villus height grip depth compared to the placebo group. And then we were also able to link that to circulating gut-homing T cells as well as interferon gamma production. So this is just an example of how T cells could be an early biomarker for tracking response to clinical outcomes. So for this study, as mentioned, we looked at 9 AChR antibody positive generalized MG patients. We used a 30-color flow cytometry panel to track antigen-specific CD4 T cells, antigen-specific CD8 T cells, and T regulatory cells. And just based on the expected response in this population, based on the HLA epitopes that they recognize, we expected about 90% of the subjects to have these circulating T cells within their blood. So I won't go too much into detail here on the assay, but essentially we took these patients' blood, isolated PBMC, and then stimulated those PBMC overnight with a couple different conditions. We used a viral peptide set as a positive control, and then we used what we're calling our core peptide set here, which was a limited set of immunodominant epitopes recognized by both CD4 and CD8 T cells. And then we also did an AChR peptide walk. So essentially we took the whole AChR protein and then broke it up into 15 mer segments. So you stimulate the cells overnight and then stain them with the markers CD154 and CD137, and then you perform magnetic separation. Once you separate those cells into the CD154 and CD137 positive, you then run them on a flow cytometer, and then you can measure both CD8 and CD4 T cells, as well as activation markers and exhaustion markers. So this is just an example of a flow cytometry plot from one of these subjects. So as you can see, this subject had a pretty strong AChR-specific CD8 T cell signature in response to both the immunodominant core peptide set, as well as the full AChR peptide walk. And then we also, again, use that flu peptide as a positive control, so you can see that they're lighting up there as well. And then just to put the data set in aggregate, going from left to right, on the left side is the antigen-specific CD4 cells, in the middle is the antigen-specific CD8 cells, and then on the other side is the antigen-specific Tregs, and these were in response to that core peptide set challenge. And so, as you can see, the antigen-specific CD4 cells, majority of these patients are expressing antigen-specific CD4 cells within their blood, and there's a pretty low inter-patient variability. In contrast, for both the CD8 and the Treg population, there is a bit more heterogeneity within the MG population. So just to summarize here, we basically demonstrated that we could track circulating AChR-specific T cells within a majority of AChR antibody-positive MG patients. In this particular study, 9 out of the 9 subjects that we tested had these circulating T cells. And then we also intend to use this assay to track response to treatment in a Myasthenia Gravis clinical trial that's upcoming. And we know just from the interpatient variability, we should have a good response within the antigen-specific CD4 population, and then for both the Treg and the CD8, there may be a bit more heterogeneity within those populations. So with that, I will stop, and I will take questions at the end of the session. Oh, and lastly, I just want to acknowledge the team. So Dr. Adam Mahaffey, who is in the audience today, was really a key driver from the core side in this study. And then I'll also acknowledge Dr. Mao-Chung Liu, who actually was the analyst that performed this study, as well as Dr. Eric Wambre, who's now at Mount Sinai, who developed the flow cytometry assay. Thank you.
Good morning. We'll switch gears to a slightly different topic. I will talk about the study, the results of the study, where we looked at racial disparities in acute care utilization outcomes in myasthenia gravis. These are my financial disclosures, and this is our research team that participated in this study. We know that social determinants of health are important in determining outcomes for patients both in neurological and non-neurological disorders, both from our clinical experience as well as literature. But the data on this for myasthenia gravis specifically is somewhat limited, and therefore our aim here was to investigate the association between social determinants of health and acute care utilization among patients with newly diagnosed myasthenia gravis within the United States. We defined acute care utilization here using 2 parameters. We looked at utilization of emergency room visits, and we looked at hospitalization for myasthenia gravis. Again, emergency room visits for myasthenia gravis. We used a database called the Optum's Market Clarity Database in order to identify patients with newly diagnosed myasthenia gravis. And in order to do this, we used an age cutoff. We used adults greater than 18 years of age, and these patients had to have at least 2 claims, diagnostic claims for myasthenia gravis, and the first claim we considered the index date or the date of the diagnosis. These patients were followed for 2 years, and you will see here below, The selection period, this was from 2010 to 2019, and we identified all of these patients and followed each patient from the index date for 2 years. Our outcomes were based on several covariates. We used multivariate regression to look at the association of these covariates with our acute care utilization parameters of interest. And you can see here the covariates. Let's see. Okay. The covariates including race and ethnicity, type of insurance, comorbidities, including the Charlson Comorbidity Index, whether they were obese or overweight, whether they had an exacerbation at the index visit, and how many outpatient visits they had, or did they have outpatient visits. These are the baseline patient characteristics. You will see here that the majority of patients in the dark blue, 57% I believe, are Caucasian. You will also see here that almost a third of the patients, we did not have data for race or ethnicity. A few things that we found in the demographic information: patients who identified as African American were on average slightly more than 10 years younger than patients who identified as Caucasian. They were also about the same amount, about 10 years younger than the overall mean population. And these patients who identified as African American also had the highest proportion of those using Medicaid as their primary insurance. Interestingly, the mean Charlson Comorbidity Index, as well as the rate of obesity, were not really significantly varied across subgroups, which is interesting because the African American population were 10 years younger, which makes one believe that perhaps these patients had more comorbidities, or at least developed these comorbidities associated at a younger age. And finally, patients identifying as Hispanic had the highest proportion of exacerbations at the index visit. This is the first outcome that we looked at, that is ED visits. It's a little bit complicated, but I think I can simplify this. You see all of the covariates here that we assessed. We assessed the association of these covariates with ED visits associated with myasthenia gravis, and that is the reference population. You see the odds ratio here. An odds ratio greater than 1 indicates a greater likelihood of that covariate being associated. And a few take-homes from here. You'll see that patients identifying as African American were about 37% more likely to have an emergency room visit in the first year. The black line or the bar is the first year, and the gray bar is the second year. So they were more likely to have a higher number of ED visits in the first year compared to the reference population. And here you will see here, patients using Medicaid were up to 2 to 3-fold more likely to have an ED visit compared with other insurance, the commercial insurance, both in years 1 and 2. And when you look at the other comorbidities, et cetera, other covariates, the comorbidities were slightly increased in the patients who had a likelihood of using the emergency room. More importantly, you'll see that the exacerbation rates, especially in year 1, were more than twofold, almost twofold likely to be associated with emergency visits if they had an exacerbation at index. And also, I guess as a surrogate, patients with outpatient visits were also more likely to experience ED visits. Let's look at the next outcome we were looking at, that's hospitalizations. You'll see a similar chart here. And you see here that patients identifying as Hispanic were 70% more likely to have a hospitalization. Interestingly, this happened in the second year as compared to patients who identified as Caucasian. And in terms of insurance, you will see here that patients using Medicare were about a third more likely to have a hospitalization for myasthenia gravis in the first year. Some of the other findings here, you'll see again the same theme. Exacerbation rates in the first year were twofold more likely, or greater than twofold more likely to have a hospitalization event in the first year. The exacerbation was at index. And similarly, you'll see that patients who had outpatient visits during that follow-up period were more likely to experience a hospitalization event, and this was both in year 1 and year 2. you'll see that some of these outcomes are different between years 1 and year 2. So what did we actually take home from this? I think there are some key take-home points. The first is that there are certain subgroups that tend to have greater use of acute care services. And this is important because acute care services may be a surrogate for more severe disease. Acute care diseases utilization places it's troublesome for the system. And these were African Americans and Hispanics. Those used Medicaid and Medicare, and increased comorbidities as well as exacerbations and outpatient visits. There are some limitations because this is a database study. But we do have to pay attention to these in order to find ways to target these populations to improve their care. Thank you. Dr. Keelhorn is up next.
Well, a warm welcome, everyone. While I try to get the slides to move forward, the logo is nice, but doesn't quite contain the interesting scientific information. Am I pressing the right button? Green, all right. Let's give it a minute. My name is Adrian Keelhorn. On behalf of the patients who gave consent for their data being used for research purposes, my fellow researchers and my co-authors, it's a great honor for me to present to you today on racial disparities between black and non-black patients with generalized myasthenia gravis. I have memorized the slides, so I can take you through it, but I probably need a flip chart for the interesting graphs. It's coming. I would think so, yeah. So my slides are not there. Dr. Habib, would you agree that we just swap a presentation and we sort that one out? So I'm going to hand over. Stay tuned. I hope the tension curve is incredible. I'm going to hand over to Dr. Roy with the presentation. And I hope to show you the slides soon.
Good morning, everyone. First of all, I'd like to thank MGFA and AANEM for giving me the opportunity to talk about our research on prevalence and diversity of myasthenia gravis in the United States. It is a cross-sectional study based on the All of Us database, which is a NIH-sponsored study. These are my financial disclosures. None are directly related to this presentation. And you can read the details if you want. Now, to this audience, there is no need to discuss about the myasthenia gravis. All of you know it is an autoimmune disease affecting the neuromuscular junction, and the patient's quality of life can be significantly impaired. It is estimated to affect more than 700,000 people worldwide, with a reported incidence rate between 6 to 30 per million person years in Europe. And prevalence rate is about 100 to 350 or even 400 in million people. Prevalence of myasthenia is increasing globally. If you look at this map showing the most recent prevalence of myasthenia across the world, the darker brown represents more prevalent disease. And the table is showing how prevalence of reported prevalence of myasthenia has changed over the years, starting from 1950s to more recent data in 2020 and afterwards. There are several countries which has reported prevalence of myasthenia within a decade or so, including South Korea, Australia, Taiwan, and you can see how the prevalence is increasing, and the graph is showing how it has changed since 1950. Interestingly, the incidence of myasthenia overall has kind of plateaued, mostly for early onset myasthenia, but there are suggestions that there is increased incidence rate for late onset myasthenia. Now, the question we asked, what is the current prevalence of myasthenia in the US, and what is the racial diversity profile of myasthenia in the US? There are few studies on the prevalence rate of myasthenia in the US, but most of them were done in the past. The most recent study, epidemiological study of myasthenia in the US, is for ocular myasthenia patients. To address these questions, we used the All of Us research database. It is a NIH-sponsored program with the intention to be inclusive of all racial diversity, and it intend to recruit about 1 million US participants. So far, they have recruited about some 400,000 or so. At the time we did our study, it was about 370,000. It includes several data, including electronic health record-based data, several genetic studies, some wearable data, and other information as well based on survey and biological testings. So when we did the study, there were about 370,000 patients. We used codes including the Systemized Nomenclature of Medicine, SNOMED, and ICD codes to extract the data on patients with myasthenia. And afterwards, we also compared this dataset with Explore MG dataset, which is a dataset based at Yale University. So based on the All of Us dataset, we found that prevalence rate of myasthenia is 0.13%. About 65% of the patients with myasthenia in this database are female, with mean age of 64. And not surprisingly, majority of the patients in this database were white, with some African American and Hispanic population, and few patients of Asian background. Now, we also looked at the distribution of the patients across the US. As you can see, there are differences between the states. Some states, particularly Massachusetts, New York, California, had a lot of patients in the database, whereas there were no patients from many states. There are about 42 patients who did not specify their state of residence. Interestingly, in terms of age of distribution, there are two graphs. The first one showing the total number of patients with different age for myasthenia, and the second one is showing the percentage. It is similar to what we have seen in the past. The patients in the white population are more in the middle age group compared to other races. And we also examined the prevalence based on the database at Yale. We have initially published our work based on the database from 2017. And now based on the updated database, you can see we have 605 patients with compared to total population in Connecticut, and the prevalence rate is 0.019%. Similar to the All of Us database, we also have majority of population is white Caucasian, and there are some differences in terms of the population. Our database are a bit younger with less female population. Now, the All of Us database prevalence rate is much higher compared to what we have seen before. The question is it true because it is a patient-initiated registry for every other disease? And it is not the case. We'll compare the prevalence rate from the All of Us database for ALS, which is exactly the same for the prevalence rate based on the global burden of disease. Similarly, the diabetic neuropathy prevalence rate is a little bit lower than what has been reported, but previous reports were mostly in diabetic patients. and the prevalence rate for CIDP from the same database is a bit higher. So MG is a heterogeneous disease, and all the previous reports on prevalence of myasthenia had a lot of heterogeneity, partially stemming from the population and also the diagnostic criteria and examining different types of patients with myasthenia. We noted higher prevalence rate from the All of Us database, and some of it might be related to the way the data was captured, and there might be some other differences in terms of patients' education and other factors. There has been not a lot of studies which looked at the racial differences in myasthenia in US. One systematic effort was in 2007, and we found some similar representation, such as the African American population had lower number of patients with a higher age for myasthenia. And we are still looking at this database to understand more about the disease severity and other associated factors, but not all the data are available yet. So the bottom line is it highlights the importance of epidemiological studies in myasthenia to ensure that we can understand the associated racial diversity of myasthenia, and we can be truly inclusive when we are designing future clinical trials in myasthenia. With that, I'd like to thank you for your kind attention.
All right, let's give it a second try. How good tech support is, usually tend to find out when things go wrong, and I gotta say the tech support is excellent. Thank you so much for your flexibility. So on behalf of all the patients, the research, and the authors, it's a pleasure and honor for me to present to you on differences in clinical care between Black and non-Black patients. Here are my disclosures, and I work as a health economist at Alexion, the rare disease division of AstraZeneca. So the background, we know that in the United States, racial health inequities exist. Neurology or neurological conditions are not exempt for that. We wanted to see what happens with patients who are diagnosed with generalized myasthenia gravis. As you know, eculizumab was approved for the use of patients with generalized myasthenia gravis many years ago. We collected data, real-world evidence on this drug, and we thought we use this data set to see if there are differences in treatment and care approaches between Black and non-Black patients. And we chose the category of Black and non-Black on purpose because this is race is self-assessed, and interaction with patients helped me realize that they usually use color to assign a racial category, and I thought, you know, as a researcher, let's just call it as what it is. We had an existing database that was a retrospective observational study. We basically used physician-reported electronic medical records data. We included a wide variety of places where patients were treated, and we used a pre-post study design. This is rare disease, so it's not easy to find these patients and then get adequate control groups. So we collected data on patients, including their outcomes as assessed by MG-ADL, up to 2 years prior to the initiation of eculizumab, and then we followed these patients for up to 2 years after the initiation. Baseline demographics, we found similar to Dr. Narayasyami and her team that we had younger patients, so the average age of patients was younger, and we had a higher proportion of females. Both of these elements are correlated. What is maybe unique in this analysis, at the very bottom you see all these patients had health insurance because they were about to initiate treatment with eculizumab. In fact, Black patients had a higher proportion of commercial insurance, which as a health economist is probably the best health insurance in the United States you can get. We begin to see differences at baseline characteristics though. You can see here that if you look at time from diagnosis to eculizumab initiation, Black patients had to wait on average 2.7 years longer. And that hurts because if you look at the MG-ADL, the corresponding one at initiation, it was markedly higher, 1.6 on average MG-ADL. That means the disease was less well controlled. We also looked at medications that patients received concomitant at the initiation. So pyridoxine mean, you see some differences, but prednisone and non-steroidal immunosuppressant therapies, you see really differences where Black patients received, a smaller proportion of Black patients received, for example, prednisone. And I put in a little call-out box the average dose. So not just that fewer Black patients received prednisone, the average dose was also lower. And what we are not presenting here, but of course we looked into this, are there any comorbidities that would warrant a more careful approach to prednisone? Black patients were actually healthier and had fewer indications for a cautious approach treating with prednisone, so that didn't hold. We noticed that the majority of Black patients, of which we had 19 out of a total sample of 119, were treated in academic medical centers. So we did a subgroup analysis here. We saw the difference between Black and non-Black patients at these centers was actually pretty similar. But of course, if you go then to the non-academic centers where the predominantly, the large proportion of non-Black patients were treated, you see a far higher utilization of pyridoxine and prednisone as well as NSAID, which results in the, if you look on the cohort level, in the differences of care we are seeing. There were some differences in reasons. Black patients cited previous exacerbations or crises and were looking for alternative options, whereas non-Black patients at the bottom highlighted aspects like patient preference or a perceived safety concern with existing therapies. So here you see the MG-ADL from initiation. See the Black patients is the dark curve higher. They started on a higher level. The nice thing is that after 6 months, no matter where you started, all patients were in a similar, much better controlled state. Of course, the delta for Black patients with a reduction of MG-ADL of 5.4 was higher because of the higher baseline, but the benefit observed in 6 months was sustained in this cohort for up to 24 months. Limitation of the study, there were imbalances, so we had 19 patients in the Black group, 100 in the non-Black group. All in all, small number, and we need to realize that race is self-reported by patients, and in a healthcare system where the level of care between Blacks and whites was different, very often we notice patients actually select a white race, so there may be a little bit of a confounding in the data we are reporting here. The conclusion is that Black patients experience a longer time from diagnosis to initiation of eculizumab. They started on this drug with a higher level of disease activity, and during their care they received an overall lower level of co-medications for disease control. On the bright side, the response to eculizumab was the same across all these two groups. And the authors thought there are many reasons that can explain this, but maybe a low-hanging fruit is a critical reflection by healthcare professionals on potentially hidden biases, because we could not explain clinically why we saw the differences, but I've done unconscious bias training myself, and there's a lot that can be uncovered that may have, in a clinical reality, reduced the observed differences between Black and non-Black patients, because I'm sure we're all striving for a healthcare system where patients are treated according to their needs and their symptoms, and not by the color of their skin. Thank you for your attention.
So I'd really, really like to thank all the speakers. You guys have made my job so much easier. Doe was not yelling at me because we are on time. I'm stalling, giving people time to step up to the microphone to ask questions from our speakers. If there are any, please step up to the microphone in the middle. Thank you, Dr. Lee, for breaking the ice here.
Nice talk. So just a few questions. One for Dr. Lee. The imbalance between the peripheral blood and the thymus gland, could that be due to the immunotherapy given this patient and what do we observe in the blood?
Thank you for your question. So your question is that immunosuppression will have an influence on the immune cell imbalance?
Especially in the blood.
Oh, yeah. So in our study, so the patients received immunosuppression treatment before the thymectomy. But from the literature, immunosuppression probably have influence on the immune cell changes, but it's hard to validate, just like the longitudinal follow-up tracking of the immune cell changes before and after immunosuppression treatment. But I think your question is yes.
Okay, for Dr. Keeman, just a simple question. How many black patient was cared at a non-academic center? What's the total number?
I think we had 4 or 5 patients. Yeah.
So it's a too small number.
Yes, that's why on the chart that was on the right side of the slide, I would not compare the two groups, but rather look at the overall amplitude of exposure in the non-black group. I think this is what we can learn from that slide.
Thank you.
Great presentations. This is a question for Dr. Roy. Very creative way of trying to address this question about incidence and prevalence. One comment, nothing that I don't think you could fix. If you look at the geographic distribution of volunteers in all of us, it's really not helpful not to include a whole part of US. Second one was, have you considered comparing with other more mature databases? So for example, I know the UK database was ahead of the US, as I understand. All of us started after the UK database, and they have 500,000 patients, so they must be myasthenics in there. Thanks.
Great question, Dr. Murpudi. Actually, the presentation is just a small overview of what we are doing. We are looking at multiple databases. All of us is one of them. We have data from UK Biobank as well, and for MG in US, apart from the Explore MG, now we have MGNet, and also big myasthenia database as well. So the goal is to incorporate all these databases together and compare what is the real epidemiology. And when we get multiple data, it actually takes us more closer to what is the truth in the community instead of looking at individual small database. Great question, thank you.
Sorry, Dr. Giran, I'm going to ask you. I just want to, there's a question from the online audience as well that I wanted to give them a chance. So this is a question for Dr. Narayanaswamy. Is there a possibility to correlate actual disease severity with healthcare utilization in your study? And how about treatment compliance?
Yeah, thank you. And I think I ran out of time a little bit, and I was too scared of Ali to continue on because he'd warned me up front that if I said anything, so that's why I was stammering at the very end. I was that scared. So yeah, one of the limitations, I mean, one of the things we wondered about was, now I'm going to take that time, there were differences between year 1 and year 2. Obviously, patients have been treated in that year 1, and so that may have been have accounted for some of those differences. But also, I mean, it may reflect differences in severity, differences in what other medications they were receiving, et cetera, which we could not actually get, and that's really one downside to using the database. This database is actually linked to EHR data, but we did not use the EHR part of this data, so hopefully the answers to that will be forthcoming. Thank you.
Dr. Giran.
So this question is for Dr. Narayanaswamy. Great talk. I had a question about defining incident MG and how important you think a run-in period, like a washout where patients are enrolled in the database but do not have a diagnosis of myasthenia, is to truly establish that that first diagnosis code is incident MG. And in a prior study that we did, we actually did 2 years of run-in to avoid the infrequent to presentation, more mild patients getting lumped into the incident diagnoses.
Right, and the expert on this is in the audience. Dr. Lee is right here. We used his criteria that validated this particular way of doing it. Yes. So the reason we didn't have a run-in period. We just needed those 2 diagnoses, and I actually don't recall the duration between the 2 diagnostic codes that we needed. So we didn't use that run-in. We just, and yes, we took the first diagnosis as the index period. Could they have had myasthenia before? We had a 10-year database, so none of them had had a code before or before that. So, and that was the reason we thought that we were fairly safe in assuming that, and they also had to have continuous coverage during that time period. So we thought we were fairly safe in assuming that. I don't know if Dr. Lee, you have any other comments about the lack of a run-in period, if you want to take that.
Hey, Amanda. I thought we used the 2-year running, but in general, I can tell you it's some of the MG patients do get into remission, and they do not interact with healthcare that much. So 2-year running period is definitely much safer than 1 year. When we look at our data we publish in our, use our single institution experience, we actually found that if you just use a 1-year study, you'll only be able to capture 70% of MG patient. There are 30% MG patients don't show up for medical health care in a 1-year period. For 2-year period, much safer, but I think there are probably a small portion of patients will be misrecognized as incident cases, but they are truly prevalent cases. They're probably less than 10% of my guess, but I think it's 10% probably does not influence the result too much.
So we are getting tight on the time, and I'm getting looks from there, so I would ask my colleagues here to keep their answers on the briefer side.
Okay. I have a very brief question. Tom Regal from Colorado for Dr. Narayanaswamy, so don't give up the microphone. Are you sure from using these databases that you're actually capturing true myasthenia? Using claim databases that we have in Colorado with these same criteria, we ended up getting a number that looked way higher than the possible prevalence of this disease using 4 visits over a 3-year period. And then with chart review of all 530 of these patients, almost half of them didn't have myasthenia, but they're using the diagnostic code for fatigue or to order a test or something like this. So is the way to make sure that what we're measuring is actually patients with myasthenia?
Yeah, there is not. I mean, you bring up the limitation of any database study, a commercial database, but even a registry that is patient-reported where you have patient-reported myasthenia. So I think that is a problem with all registry studies, unless you have a prospective registry where it's a clinician-reported, you have the diagnostic features.
Hello, another question for you. You mentioned that Hispanics had a highest proportion of exacerbations. Was that first and second year, or that was through the whole?
I'm sorry, say that again. A highest proportion?
You mentioned that Hispanics had a higher proportion of exacerbations. That means ER visits or just exacerbations throughout inpatient?
Yeah, so the exacerbations were measured at the index visit. There's a code for myasthenia gravis with exacerbation. So because exacerbation was a covariate, so we measured the exacerbation at the index visit and saw if that predicted acute care utilization.
So to that, the question was, why do you think Hispanics patients will be admitted more to the hospital during the second year?
Yeah, I don't know. So it's possible that their disease is still not as controlled as the other people. So unless we have data for severity and data for other characteristics of treatment, I'm not sure we can actually go there. So, and that's what I mentioned. There's some differences between first and second year data that we are still sort of looking into.
That's interesting. Thank you.
Hello, I have a question to the Dr. Janardi about the T-cell, antigen-specific T-cell assay. So have you used the epitopic peptide or the whole size full-length protein for the T-cell assay? The second question is, do you have a plan to make a T-cell clone, or including the regulatory T-cell you guys really isolated?
Yeah, so just so I understand the first half of that question, you said, have we used a different protein set?
No, I just want to know to perform your T-cell assay, which is specific for the antigen, you use a whole protein or the specific epitopic peptide?
Yeah, so all of the, we actually use, for the AChR, we used a set of amino-dominant epitopes, so each of those were 15 to 20 mer amino acids in length. And then for the full AChR protein, we actually chopped it up into 15 mer segments. And then for your second question, do you mind repeating?
Have you generated T-cell clones specific to the antigen?
Oh, yeah. We have not to date. That's definitely something interesting to look into the future. But yeah, to date, we've only looked at within the blood peripherally. Thank you.
Awesome. Thank you, everyone. That was a fantastic first session. While this is break, it really is also a time for checking out all the posters, and there's a lot of posters there. Please go visit them. They're kind of diagonally to the left. If I can ask everybody to try and start heading back at 10 o'clock, so we have a few minutes to settle down.